Hello, I'm Manoj Karmakar. Welcome to yet another video on issps TV. In this next video, Professor Vincent Chan from Toronto in Canada is going to share with us how you can perform a point-of-care gastric ultrasound. If you like any of our videos, do remember to like and share it with your friends. If you are new to this channel, do remember to subscribe so that you can get regular notifications of any future uploads. Now enjoy the upcoming video. We're waiting for Dr. Osman. Vincent, there is a question for you. The question is, when you do gastric ultrasound, do you mostly use one single plane view, or do you use alternative views if it's difficult in patients with, say, morbid obesity?
Again, the most useful views for, I hear quite a bit of feedback. Again, the most useful view is the right lateral decubitus when you use the result to plug into the table to do a quantitative measurement, right? So if it's fluid, you want to know whether it's greater than 1.5 mils per kilo. So the right lateral decubitus view is the most important. And in terms of the stomach view, you want to get the cross-sectional view as much as possible, because if it's an oblique view, you may have also overestimated the size of the antrum. So that's the usual. So do supine first, since the patient usually start in the supine. If it's full, if you already can see the stomach qualitatively, you know it is a big stomach. If you want a quantitative assessment, definitely go for the right lateral decubitus, or if the patient cannot go on the right side, then do a semi-sitting position.
Thank you, Vincent. Here's a question for you, Adi. An anonymous attendee asked about what would be your experience with the use of ultrasound during cardiac arrest.
We know now there's a lot of evidence have shown that our chest compression is actually not that accurate. Okay? One of the things that we're doing now, hopefully we come up with the result, is actually using a transesophageal echo, look at to determine the best area for chest compression. And what we found is every time we do a chest compression using a typical landmark, then we suggest you not only compress the left ventricle, you also compress the LVOT. But I think Pilipekteran from Penn University have published an article a few months back in resuscitation proving this evidence. Right? So we do use lung ultrasound. I think this is not new. I think it was started probably more than 15 years ago. Okay, there's protocol about it. So we do use lung cardiac ultrasound for cardiac arrest, especially our main reason why we use to look at number one, etiology, things that we might miss, for example, cardiac tamponade. Number two, we want to look at whether we actually compress the LV rather than compressing some other things, for example, RV. And the third thing, whether we actually compress the LV together with the LVOT. So we do a lot. We do use it a lot now.
Thank you, Adi. Here's another question from another anonymous attendee who says, which dynamic parameter do you use to evaluate fluid responsiveness in the setting of acute RV failure?
I think for RV failure, even though there's not much evidence, I think some people believe that things like non-ultrasound usage, for example, using the PPV, pulse pressure ablation. I do use LVOT VTI in RV failure
Vincent, this is a question for you. It's my thoughts, really. Now that your team has developed gastric ultrasound to a point where you can quantify it very simply, do you think it should become an integral part of our assessment in the pre-operative scenario, particularly in the emergency setting?
I think more and more so we are going towards this direction. Obviously, there's no guideline right now. It's more impression or a opinion of our part. I think particularly for emergency cases, particularly you cannot get a history, particularly about the NPO status, particularly if it's about obstruction. I mean, either you can look at a CT scan to look at the stomach volume or do the gastric ultrasound assessment. I think the key here is, what do we want to know more? We know it's a full stomach, but is there anything that we can do further to reduce the volume inside the stomach? I think that is the key. It's not a matter of a full stomach precaution or not. We obviously will do the rapid sequence induction and so forth. But is it going to be the routine? I don't know. I think time will tell. But one other thing is, we cannot prove that gastric ultrasound will decrease the number of pulmonary aspiration. We need a huge number. Just like any point of care ultrasound application, it's helpful, but we cannot prove that lung ultrasound can reduce morbidity, mortality of pneumothorax. So this is the outcome data that we don't have. So we cannot say you need to do this in order to reduce the risk. You can reduce the risk of pulmonary aspiration, but you don't know exactly what's the impact, the outcome impact of doing this.
Thank you, Vincent. That's a good response. Now, on the flip side, now there are many patients where we do rapid sequence induction with not much evidence. Now that you can quantify it, would that be a good reason to say, oh, this patient does not need a rapid sequence induction? Because there are risks associated with the use of succinylmethonium and so on and so forth. So what would be your philosophical answer to this? I mean, because there are many indications where we'd still do rapid sequence induction because there have been a few cases reported. Say, for instance, after trauma, people say they have a full stomach, but there is not really solid evidence to support that. But I think it is quite common that we do rapid sequence, even in young children who've had a fracture forearm, they're coming for a closed reduction. They still undergo this kind of rapid sequence. What are your thoughts?
If you are confident with your assessment, if you know that your assessment is accurate, there's not, the full stomach is not present, then yes, I would just go ahead with a general anesthesia, even without airway, securing the airway with endotracheal tube, or just use a LMA if I am confident with my assessment that there is no full stomach. So the key thing is do enough that you're confident, look at enough gastric ultrasound images and videos to make sure that you can accurately diagnose. And this is where we find most helpful is the elective cases, when patients have eaten. Is like, do we go ahead or not? Do we need to intubate the airway or not?
Thank you, Vincent. Thank you, Adi.